Hello, and welcome to the American Medical Association's Project Firstline Measles Update. The Centers for Disease Control and Prevention's Project Firstline provides innovative and accessible infection control education for all frontline healthcare professionals so they can protect their patients, their coworkers, and themselves from infectious diseases threats in healthcare. This particular webinar is a joint effort between the AMA and CDC. I'm Erica Kaufman-West, the Director of Infectious Diseases at the AMA. While measles was declared eliminated from the United States in 2000, we continue to see outbreaks in communities where vaccination rates have slipped below what is required to maintain community immunity. Globally, measles outbreaks are occurring in almost every region of the world, and there are still many countries with variable access to measles vaccines. Measles typically enters the U.S. through unvaccinated or undervaccinated people who return here with an exposure overseas. CDC supports countries with large measles outbreaks and countries with limited healthcare infrastructure, low immunization rates, or gaps in coverage that make it more likely for outbreaks to spread and cross borders. With spring break travel happening now and summer break around the corner, the American Medical Association and CDC have been urging everyone who isn't vaccinated against measles to get vaccinated. Vaccination prevents infection to the individual, but it also helps prevent further spread to loved ones, neighbors, coworkers, and others in close contact. Remember, some children are too young for vaccination, and others are at risk despite vaccination because of weakened immune systems from chemotherapy or other immunosuppressants. It's of the utmost importance that physicians and other healthcare professionals talk to their patients about the health risks associated with missed vaccines and to make strong recommendation for vaccination unless medically unadvisable. Many physicians in the U.S. have never seen a case of measles, which is why we are bringing together CDC experts to discuss the current outbreaks, traditional signs and symptoms of measles, and healthcare infection prevention measures to protect ourselves when we have a patient with suspected measles. To begin, we have a video to share with you from Admiral Rachel Levine, who serves as the 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services and the head of the U.S. Public Health Service Commission Corps. She fights every day to improve the health and well-being of all Americans. She's working to help our nation overcome the COVID-19 pandemic and build a stronger foundation for a healthier future, one in which every American can attain their full health potential. Admiral Levine's storied career, first as a physician in academic medicine, focused on the intersection between mental and physical health, treating children, adolescents, and young adults. Then, as Pennsylvania's Physician General, and later as Pennsylvania's Secretary of Health, she addressed COVID-19, the opioid crisis, behavioral health, and other public health challenges.
Summer is right around the corner, and many Americans are planning travel both around the country and internationally. But there are communities here and countries abroad where measles vaccination rates have declined, making the risk of outbreaks greater. We are currently seeing this in certain states and in a number of European countries. That's why vaccination against measles is more important than ever. The measles virus doesn't respect state lines or country borders, and families who are not fully vaccinated may bring home more than just vacation memories. Public health partnerships and infrastructure are critical. I want to take a moment to recognize the CDC and the state and local health departments and healthcare providers for their role in protecting our families and communities. You as clinicians are our first line of protection against measles. You have your pulse on your patient's health and continue to have the important vaccine conversations that foster confidence and bolster vaccination rates. Nationally, the rates of people vaccinated against measles have been high and stable since the Vaccines for Children, or VFC, program began measuring vaccine coverage in 1994. VFC's success and vaccination efforts from healthcare providers like you have led to a greater than 99% reduction in measles cases compared to before the vaccine was available. Because of these successes, the United States has maintained measles elimination status for almost 20 years. But Sobering news. At the county or smaller local levels, vaccine coverage rates may vary considerably. Pockets of unvaccinated people can exist in states with high vaccination coverage, underscoring considerable measles susceptibility at some local levels. Today, join us on this call as public health and clinical practice intersect to keep measles where it belongs, eliminated.
I'm honored to introduce our first live speaker, Dr. Dmitri Daskalakis. Dr. Daskalakis is the director of CDC's National Center for Immunization and Respiratory Diseases. Most recently, he served as the director of the Division of HIV Prevention in CDC's National Center for HIV, Viral Hepatitis, STD, and TB Prevention. Dr. Daskalakis has been recognized as an expert in HIV prevention and has focused much of his career on the treatment and prevention of HIV and other STIs. He also served as the deputy coordinator of the White House's Mpox response, where he successfully led vaccination and public health education efforts. Dr. Daskalakis began his career as an attending physician at Bellevue Hospital in New York City, where he spearheaded several public health programs focused on community HIV testing and prevention. He has since served in several healthcare and public health capacities in NYC, including the Deputy Commissioner for the Division of Disease Control at the NYC Department of Health and Mental Hygiene. Dr. Daskalakis, I'll turn it over to you.
Thank you very much. And I want to also say thank you to Admiral Levine for the kind words that you just heard, highlighting the work of CDC, state and local health departments, and healthcare providers. And again, thank you all for being here today, and thank you to AMA for hosting us to discuss this important topic. So we continue to see measles cases increase in the United States. This is driven by several factors. We're seeing declines in measles vaccination rates globally that have increased the risk of measles outbreaks worldwide. The US is on that globe. And so when we see global measles increasing, the United States is always also at risk. Outbreaks in countries to which Americans often travel can directly contribute to an increase in measles cases in the US. Domestic measles outbreaks have been reported in most years, even following the US declaration of measles elimination that you heard about earlier in 2000. The important news is that measles is a foe that we know. It is almost entirely preventable through vaccination. The measles, mumps, rubella, and other measles-containing vaccines are safe and highly effective. One vaccine dose is 93% effective, and 2 doses are 97% effective against measles. It's important to note, and you're going to hear a lot more about this with subsequent speakers, most measles importations come from unvaccinated US residents. And in recent years, these importations have come from popular travel destinations, including, but not limited to, the Philippines, Ukraine, Israel, Thailand, Vietnam, England, France, Germany, and India. So to prevent measles infection and reduce the risk of community transmission from importation, it is really important that all US residents traveling internationally, regardless of destination, should be current on their MMR vaccinations. That means that we need to make sure our patients are protected against measles before international travel. And ideally, that full vaccination should occur at least 2 weeks before their international departure. To emphasize this, on March 18th, CDC issued an alert that informed clinicians and public health officials of an increase in global and US measles cases, and also issuing guidance to prevent measles outbreaks. We at CDC are currently working with public health departments across the country by providing both remote technical assistance and also support on the ground at the request of health departments, as well as clinical tools for healthcare professionals. At the county or lower levels, vaccine coverage rates may vary considerably. Pockets of unvaccinated people can exist in states that we know have high vaccination coverage, posing considerable measles susceptibility at some local levels. Outbreaks can occur when measles gets into communities of unvaccinated or undervaccinated people in the US. I want to give you a really important statistic. Vaccination coverage among US kindergartners has decreased from 95% during the 2019 to 2020 school year to 93% in the 2022-23 school year. That sounds like only 2%, but that 2% means that there are approximately 250,000 kindergartners who are susceptible to measles each year over the last 3 years. Also, we know that exemptions over 5% at the local level limit the level of achievable vaccination coverage, which increases the risk for outbreaks of vaccine preventable diseases. So it's really important that we take non-religious exemptions and look at them very carefully to make sure that they're appropriate. 36 states, plus the District of Columbia, had less than 95% MMR coverage among kindergartners during the 22-23 school year. So, big message. We encourage healthcare providers, thank you for being here, to ensure that all patients are up to date on their MMR vaccine. And I'll thank you for all that you do to keep us safe from diseases such as measles. I'll turn it back over to you. Thank you.
Thank you, Dr. Daskalakis. Our next two guests will give an overview of measles as a disease and where we are today. Captain Sugarman is a medical officer in the Division of Viral Diseases, serving as team lead for the measles, rubella, and cytomegalovirus team. During his CDC career, he played key roles in the agency's injury prevention, global field epidemiology, workforce development, and vaccine preventable diseases work. He's an alumnus of CDC's Epidemic Intelligence Service program, assigned to the San Diego County Health Department and CDC Quarantine Station. He graduated from Thomas Jefferson Medical College, completed a Master's of Public Health at the Johns Hopkins School of Public Health, and his residency in emergency medicine at the Johns Hopkins Hospital. Dr. Dan Filardo is a physician trained in internal medicine and adult infectious diseases. He joined the CDC as an Epidemic Intelligence Service Officer in 2021 with the Division of Tuberculosis Elimination and has served as a medical officer with the Measles, Rubella, and CMV team since 2023. We will share your slides and we look forward to your presentation.
Wonderful. Good afternoon, everyone. Thanks so much for joining and tuning in. Measles is an acute febrile rash illness caused by the measles virus. It can be particularly challenging in the healthcare setting as patients are infectious during their prodromal phase, 4 days before rash onset, when measles may not be considered by providers. It is transmitted by direct contact with infectious droplets and can also be spread by the airborne route. Measles is highly contagious. 90% of susceptible household contacts will develop illness if exposed to a measles case. The estimated reproductive number, or R0, is 12 to 16 in an unvaccinated population, meaning that a measles case would be expected to result in 12 to 16 secondary cases. Measles presents with a prodrome that typically lasts 2 to 4 days, characterized by fever followed by one or more of the 3 C's, cough, coryza, or conjunctivitis, which intensify until the rash appears. The fever may be as high as 105 degrees Fahrenheit or 40.5 degrees Celsius. According to the Council of State and Territorial Epidemiologists, or CSTE, case definition, fever, rash, and one of the 3 C's must be present to be considered a clinical measles case. Classically, measles starts at the hairline or behind the ears and spreads centrifugally downward to the neck, trunk, and extremities. The rash is erythematous, maculopapular, and blanching early on and less blanching later. The rash may include petechiae in severe cases, and it may appear hemorrhagic in very severe cases. The palms and soles are rarely involved. Up to 4 days before the rash, patients may develop Koplik spots, which are 1 to 3 millimeter whitish, grayish, or bluish elevations with an erythematous base, typically seen on the buccal mucosa opposite the molar teeth, described as grains of salt on a red background. While they may improve diagnostic accuracy prior to rash onset, they are not seen in all patients. This is a photo from, please, next slide. Around 20% of unvaccinated measles cases are hospitalized. most often due to diarrhea and dehydration, with more severe complications including pneumonia in 1 to 6%, encephalitis among 1 in 1,000 cases, and even death in 1 to 3 per 1,000 cases. Also, there can be a delayed fatal neurologic condition called subacute sclerosing panencephalitis seen in 1 to 5,000 to 10,000 cases. Complications are more common and severe in those under 5 and older than 20 years of age, especially among those that are immunosuppressed. Now I'm going to review US measles case data between 2001 and 2023. Measles was declared eliminated in the US in the year 2000. And during 2001 to 2023, we've seen a median of 72 measles cases reported each year. Incidence per million population is shown by the yellow line, which has remained below 1 case per million, indicated by the red dashed line, in all but 3 years, 2014, 2018, and 2019. Large outbreaks were reported in each of these years. Here are the reported measles cases from January 1st, 2023 to March 21st, 2024, displayed in an epicurve to the left and a state map to the right. These figures are updated each Friday at noon Eastern Standard Time on the CDC Measles Cases website. In 2023, 58 cases were reported by 20 jurisdictions, with 1/3 of those cases reported in December of 2023. As of March 21st of this year, we've already surpassed that 2023 total, with 64 measles cases reported by 17 jurisdictions, indicated on the map to the right.
So now I'd like to speak with you about measles vaccination. For routine prevention of measles in the United States, the Advisory Committee on Immunization Practices, or ACIP, recommends a routine vaccination schedule with a first dose between the ages of 12 to 15 months and a second dose for children between the ages of 4 to 6 years before or at the time of school entry. International travelers are considered to be at high risk for measles exposure, and the recommendations differ for international travelers. For international travelers aged 6 months or older, ACIP recommends 1 documented dose of MMR prior to departure, ideally at least 2 weeks prior to departure. And for international travelers aged 12 months or older, ACIP recommends 2 documented doses of MMR prior to departure, and these doses must be separated by at least 28 days. Measles vaccination is highly effective. To demonstrate that, we've shown the number of reported measles cases over time since the vaccine was licensed. As highlighted, the MMR vaccine is highly effective, with a first dose efficacy of 93% and a second dose efficacy of 97%. Following introduction of measles vaccination in 1963, the US went from an estimated 3 to 4 million cases of measles per year to a median of less than 100 cases per year since elimination was declared in 2000. So next we'll talk about international travel risk for measles. So measles remains endemic in many countries in the world, and measles outbreaks can occur anywhere in the world. During 2001 to 2023, more than half of imported measles cases in the United States were reported among travelers to countries in the European or Western Pacific regions. The top 5 source countries for importations during this time were India, the Philippines, China, Pakistan, and the United Kingdom. This figure shows data from the World Health Organization, or WHO, and shows the number of reported measles cases per country in the 6 months leading up to March 2024. Measles cases have been reported from nearly every country on the globe during this time, and 20 countries have reported 1,000 or more cases of measles during this 6-month period. And these are shown in the darkest blue on this figure. The World Health Organization has warned that by the end of 2024, over half of the countries in the world will be at risk of a measles outbreak, and that about half of these are low and middle income countries globally. And WHO estimates that 142 million children under the age of 5 are susceptible to measles globally. We also want to highlight that there has been a recent increase in measles in the United Kingdom and broadly in Western Europe. The figure on the left from the UK Health Security Agency shows over 700 lab-confirmed measles cases that have been reported during October 2023 through March of 2024, with the majority in the West Midlands region of England. However, the London region has also been affected by this outbreak, and modeling work suggests that the London region is at risk of a large outbreak. This is extremely important to highlight because historically the United Kingdom has been among the top 5 source countries for measles importations into the United States, and it's a common travel destination for travelers from the United States. However, it's not a country that most Americans think of as an area that would be at risk for measles exposure. While we have not seen any imports from the United Kingdom to the United States thus far in 2024, it's possible that this could change as we approach the spring break and summer travel seasons. And on the right side of the slide, the European CDC has also reported increased number of cases in Western and Central Europe, including outbreaks in Austria and Romania. So to round out our presentation, I wanted to focus on a couple clinical aspects of measles. First, for clinicians seeing patients with measles-compatible symptoms, it's important to consider the likelihood of measles by thinking about the clinical case definition, which we reviewed earlier, the patient's prior vaccination status, given that measles is less common in those who have been previously vaccinated, and assessing the travel or exposure history in the 21 days before their illness. For patients with a febrile rash and recent international travel, measles should be strongly considered. And finally, I wanted to briefly highlight some medical countermeasures that are available in the context of measles response. For people exposed to measles, who are either not protected against measles or at high risk of severe measles or complications, post-exposure prophylaxis is available, either in the form of MMR vaccine or in the provision of immune globulin, which can both be given as post-exposure prophylaxis. Regarding treatment, unfortunately, there is no licensed antiviral specifically for the treatment of measles. Historical studies have shown that vitamin A can prevent measles complications, especially in children with severe disease or requiring hospitalization. CDC therefore recommends vitamin A supplementation for all children with severe disease or requiring hospitalization for management of measles. Thank you very much.
Thank you. And now I'm happy to welcome Dr. Michael Bell to our discussion. Dr. Bell is the acting director of CDC's Division of Healthcare Quality Promotion. Prior to that, he served as the associate director for infection control and was the executive secretary for the U.S. Healthcare Infection Control Practices Advisory Committee. His career has focused on investigating and preventing transmission of healthcare-associated illness, development of evidence-based infection control guidelines, and optimizing systems of care. Dr. Bell, thank you for sharing some of your opening thoughts.
Thank you. Very happy to be with you, and thanks for everyone's time today. I have just a few very short messages. The important information you just heard about the value of immunization and the effectiveness of post-exposure immunization really can't be overstated, and it is ultimately the primary approach for this particular disease. And I say that with all of the background of infection control that I normally want to push forward. In this case, it is largely secondary. I will say that for healthcare facilities, now is the time to be refreshing awareness And this is something that I think needs to include not just clinical staff, but whoever is manning the reception intake areas, your front desk, and also patient and family members who need to know what to do. Just like we did with COVID, we alerted people to notify the clinical staff before they arrive. If you have a little kid who is having a high fever and has a cough or cold, even with or without a rash, I think reminding people to flag that so that before the patient arrives, the clinical staff can be prepared. That preparation may be to keep them out of the waiting area and even out of the facility. It may be possible not to have them come in at all. And frankly, that reduces the amount of post hoc tracing of individuals that you might have to do. On the exposure tracing piece, this is also a good time to look and see whether you have reliable ways to understand what other patients or individuals might have been in the area where a potentially infectious patient was identified. It's a good time to make sure that your occupational health records are also up to date and easily accessible. You have a short window of time, a day or so, to notify people that they need to be immunized if they were exposed and not immune. And so making that efficient as possible is part of what we need to be preparing right now. I think the practices and requirements for occupational immunization vary by location. If you're in a place where there's any option for not being immunized against measles, in order to work in the healthcare setting, this is a good time to review who's not immune. And if their reasoning is not completely limiting, to encourage them to become immunized. There is the standard admonition that I'll repeat. You've heard it 100 times. And that is, if you've got someone with a fever and a rash sitting in your waiting room, that's a mistake, right? They shouldn't be sitting there languishing and breathing around other people. You need to get a mask on them as soon as possible, get them into a separate room. If you do suspect measles and they're going to be coming into the hospital, that's when the infection control practices for isolation take hold. And these are patients that we care for in a negative pressure isolation room under airborne isolation precautions. That means anyone going in the room wears a respirator, fit tested N95 or better, PAPRs work. And the patient, if they're coming out of that room for any reason, they wear a mask the entire time they're outside of the room, if they're able to comply. Notwithstanding, it's best not to have them traversing your facility unnecessarily. And similarly, we don't want extra people coming to visit if we can avoid it. So limiting exposure of others is really top of the line after vaccination. The last thing that I'll say is notification needs to be prompt. So if you suspect that you have someone like this arriving for care, if you suspect that others might have been exposed, immediate notification of your infection control team, of your occupational health service, and the health department really need to happen right up front. The faster we can react and contain secondary spread, the better off we'll be. For those of you who heard the R naught of 16 and didn't flinch, for context, influenza is like an R naught of 1.5, right? 1.5, maybe 2. And so when you compare that, the efficiency with which measles can spread is really profound. So the faster you can jump on it, the faster you notify, the better off the community will be. So I'll stop there and thank you again for your time.
Thanks, Dr. Bell. I'm excited to start with our Q&A portion of this webinar. I'm going to start with some of the registration questions. I know that a lot of people have been putting questions into the chat, and we'll continue to collect those, and I'll get to those as soon as we can. The first question is for Dr. Filardo. Our immunization schedule provides MMR vaccines to children. Are you recommending any MMR boosters for older adults? Should we be worried about waning immunity in the older population?
Thanks for that question. Our guidance is really to for adults to really get up to date on the existing recommendations. So CDC considers people who received 2 doses of measles vaccination as children, according to the routine vaccination schedule that I highlighted, protected for life, and they do not ever need a booster dose. There are Currently, no recommendations for a third dose of MMR vaccine to improve protection against measles. Generally, adults without high risk for measles exposure with one documented dose of MMR are considered up to date on MMR vaccination. However, certain adults, such as those planning to travel internationally, as I highlighted, adults who work in healthcare settings, or adults who attend college or other educational settings beyond high school, are recommended to have 2 total doses of MMR for up-to-date protection.
Great, thanks for reviewing the immunization recommendations for us. Dr. Bell, I'd like to come back to you. People with measles or concern for measles often show up for care first in the emergency department or maybe in urgent care. What are some actions that emergency departments and urgent care personnel can take to prevent themselves from a measles exposure?
So before the exposure, it's the immunization piece. I'll be persistent here. I am extremely comforted by the fact that I am immune, and I can approach a sniffly, febrile kid without having to think about the measles question for myself, or about the concern of spreading it to someone at home after I finish working. So the immunization piece can't be overstated. I think that, as I said earlier, the waiting room is a weak spot. It's gotten better thanks to COVID, frankly. There's a lot less of a likelihood of people waiting in a waiting room with a febrile illness for a long time. I think we've learned a couple of lessons there, but it is notwithstanding a great time to review your arrival process and do everything from posting signage to updating your outgoing phone messages or your website for scheduling, so that as many opportunities as possible are taken to inform people before they arrive, to let people know that they should alert front desk staff to what is going on, especially if it's something that could be suspected as measles. And then lastly, having a plan for efficient movement of someone if you decide that they're at high risk. In other words, after you find the person with the fever and the rash and the complex spots, that is not the time to be setting up a process for getting them to the right spot. Now is the time to identify the private room that you're going to use, where you're going to keep the mask supply, and how you're going to, again, notify infection control, notify occupational health, and let the health department know if you truly suspect measles.
Great, thank you for those reminders. Preparation ahead of time is always better than the panic after. Dr. Sugarman, we'll turn to you for this next one. As we look forward to a season of travel here in the United States, how do we protect people who will be taking these international trips, including people who cannot receive the MMR vaccine?
So let me just reiterate Dr. Flato's comments. It's going to be really critical for families traveling internationally to get that first dose for their infant 6 to 11 months of age. And that's not part of the routine series, but for those traveling internationally, it is recommended. And then it needs to be 2 doses for those that are 12 months, years of age, 2 weeks prior to travel. And so if you've got 1 dose for a child that's 12 to 15 months, and they wouldn't yet be due for their second dose to 4 to 6 years of age, and say they're 3 years of age and you're traveling, they should go ahead and get that second dose early before they travel internationally. Then there are those that may have immune compromising conditions or contraindications to immunizations. I think they should really strongly consider whether or not they should travel internationally. There's the possibility of providing immune globulin to them, intravenous immune globulin, but that should be sort of a risk-benefit conversation with providers. And just to emphasize again that vaccination is so important for those traveling internationally, because all of our cases in the US are from importation, and that can easily be spread to those that have a contraindication to immunization and can therefore also have very severe disease from that importation. Thank you.
Great, thank you. Thanks for those reminders. Dr. Bell, back to you. We had a great question come in about long-term care facilities. So if you could please touch on any considerations for both the healthcare professionals as well as the residents in long-term care being exposed to measles.
So depending on the long-term care facility, if you're talking about older adults, you're dealing with a somewhat different population, but long-term care in this day and age can mean a variety of things. If you're dealing with a long-term care facility that has high acuity, higher risk patient populations, especially those of a younger age group, this is, again, an important time to be assessing whether they are up to date with immunization. It's such an easy thing to do. And if they are agreeable to having that done, that makes a lot of difference up front. Really, the last thing you want to do is have an incursion of measles that could have been prevented. I think the occupational health side of it is similar. There, regardless of the patient population, having staff be up to date with their immunizations is key, because you don't want somebody coming in thinking they have a cold and then shedding measles, and heavens forbid you have somebody who wasn't vaccinated for medical reasons become exposed. So that is, again, I'm a broken record today, an important thing to remember. But then the last piece I think here is visitors. Depending on the type of long-term care facility, visitation plays arguably a larger role than a lot of acute care settings. Certainly, it's different from an outpatient setting. And so if visitation is a mainstay of the facility, then educating family, friends, others who might be coming to visit to not come, to delay if they think they might be ill. And the good news is they probably don't have measles. And so if a few days pass and they're not having a rash and they feel better, then they can come. So, it's not don't come, it's delay for a few days. And that may be a reasonable message to send. Similarly, sharing the information, whether it's on front door panels, websites, posters, you name it, of what measles is. As you said, not only have clinicians sort of lost touch with acute measles, but the general public hasn't seen that much of it either. And so sharing the pictures that are available on the website, printing those out and sticking them on walls, and asking people to remain alert for that. And again, if the grandkids don't need to visit today, next week might be a better choice. And so that delay tactic, I think, is worth sharing and promoting.
No, and probably a good idea to delay keeping whatever those germs are out of that facility, if at all possible. Thanks for that reminder.
One other thing before we move on, and I could have said this earlier as well, but in case people are wondering about cleaning and disinfection, all of the routine cleaning and disinfection products that we use in healthcare facilities are appropriate. Your normal hospital disinfectant works just fine for this category of viruses. So there's no need to do anything different, but you do need to make sure that the proper things are being done routinely.
Oh, appreciate that. Thank you. Another audience member wanted some clarification on MMR vaccination expectations in the acute care facilities. So maybe Dr. Bell, I'll ask your advice on that when talking about whether and when healthcare workers can opt out of vaccination in an acute care facility.
Oh gosh. So I don't have a satisfying answer for you. There's nothing materially different about we as human beings in a healthcare setting and when we're not there. And so vaccine recommendations are what they are. That said, depending on your jurisdiction, there can be different rules. Some places have very stringent rules requiring vaccination. Other places have a little more lenience. And I think the best thing to do is to address this with the Occupational Health Service and find out what their requirements are. The fact that it varies across such a large country makes it challenging, but it really is more about local decision-making and not about whether the vaccine is good or works. That is the science side. The policy side varies with where you're at.
Dr. Filardo, we have gotten a lot of questions through registration and also here in the chat about people who aren't sure of their immunization status or their patients aren't sure. Are you recommending MMR boosters for people who don't know their vaccination status?
Yeah, so broadly, if an individual is unsure about their vaccination status, the first thing we recommend is just that they try to find historical vaccination records or documentation of measles immunity. If they're unable to locate any documentation of measles immunity or their vaccine records, and they're unsure if they've received MMR vaccine previously, then we do recommend that they should receive an MMR to get up to date with adult recommendations that I provided previously. There's no harm in getting another dose of MMR vaccine if an individual may already be immune to measles or mumps or rubella for that matter. And so there's no harm to getting another dose and getting up to date on those recommendations with documented MMR doses. As an alternative, in consultation with their healthcare provider, patients who have an unknown vaccination history without documentation can also have a measles IgG titer drawn as a standard blood draw to assess for that evidence of immunity.
Thanks for that. It's always difficult trying to find those records that your mom had when you were small. Dr. Bell, coming back to you, having just come out of the COVID-19 pandemic, we know that for respiratory and airborne infections, putting a mask on a patient qualifies as preventing exposures to others in the room in case for some reason an N95 or PAPR is not immediately available for staff. Is this also the case for measles, since it's so much more contagious of a virus?
That's a terrific question. I'll start by saying that putting a mask on a patient coughing with a runny nose and a fever is never a bad idea, right? It's not going to hurt to do it. Is it enough given the efficiency with which measles can spread? I don't know that we have a precise answer, but I wouldn't bank on it. I think that getting the patient masked and in a separate space as quickly as possible is thing number one. Having people providing care for that individual wear a respirator is thing number two, and then identifying the negative pressure isolation room that you want them in is thing number three, and ideally in very rapid succession.
I appreciate that. I have a follow-up question for you in a similar sort of manner of talking about healthcare professionals and exposure. There are very busy pre-hospital providers, such as paramedics, that are really on the front lines. And what can they do to protect themselves and their communities in the receiving hospitals from spreading measles, especially considering the confined space of the ambulance and that prolonged sort of hang time of measles in the air in such a confined space?
Great question. So the good news is we have a vaccine. So if you're going to be providing care for individuals and transporting them when they might have measles, being vaccinated is thing number one. Again, I'm a broken record, but it is what it is. There is no harm in putting a mask on the patient while you're transporting them if they can tolerate it. Very young children may have difficulty with that. So again, vaccination is preferable. Even if you're vaccinated, it's good to go ahead and put on a respirator. Why not? We can sometimes be wrong with our empiric diagnoses during transport. So this is much more about covering all your bases. I think the measles vaccine part just covers you for measles, mumps, and rubella. But on the off chance that the child or person has something else, masking them, putting on a respirator for yourself is not a bad idea. There have been suggestions or recommendations even about keeping windows open in the back of the truck. And so greater air exchanges is not a bad idea. It has to be done, with the common sense of, like, if you're in an extremely smoky, smoggy place because of wildfires, the net benefit may be low. So, the common sense piece there still rules. At the other end of the spectrum is the notification of the receiving facility. Again, this is a great opportunity to give the receiving facility a heads up, saying, we've got a kid with a rash and a fever, we've got them masked, but they're pretty sick and they're probably going to need to come in. Please be ready. That lets everyone set up a system to receive the child safely and provide appropriate care.
Thank you. Dr. Sugarman, coming back to you for this one. We know that with some viruses, asymptomatic spread is a concern. What about with measles? Do travelers have to be symptomatic to spread measles?
Yeah, they really should be symptomatic to spread measles. Let me just review what I had mentioned earlier, but we consider people infectious 4 days before that rash is present. That's usually that fever, cough, coryza, conjunctivitis, these prodromal symptoms. That's a range of 1 to 8 days with an average of 2 to 4. And so people should have some degree of symptoms, but it's not always that they remember or present with symptoms or realize. It may just be slight malaise as it progresses to fever. And so as we think about contact tracing around people that have measles, we do consider this period 4 days before rash. And that might be a period longer than for which someone may remember having actual symptoms. But truly, we think of that transmissibility occurring once people have some degree of prodromal symptoms, occurring to rash as day 0, and then 4 days after that rash being infectious as well. And so all of our public health work around measles cases and all those exposed extend 4 days before and 4 days after that rash onset, which clearly makes it challenging because there can be quite a number of contacts. And even for people to remember where they were 4 days before rash onset can be a challenge. Like with foodborne investigations, what did you eat 4 to 7 days ago? Remembering where you were even physically can be hard with people moving around as much as they do these days. So, but in essence, should have symptoms to be transmitting measles. Thank you.
Yes, do have a follow-up question that came through in the chat. For people that suspect they have measles, is it required that they come in? We've been talking about exposures to the, coming into an emergency department or urgent care, but if they think they have measles, is it essential that they be seen by a physician?
It's not, and I think that Mike, Dr. Bell pointed to this earlier on, but that if they can call their provider and mention the symptoms they're having, that there can be guidance provided so that they don't enter a healthcare facility unless they really need advanced medical care. We often do like to test patients, and so organizing with public health for either testing outside of the hospital setting or testing with a pre-call to make sure that they go to a select area that has negative pressure or is in a separate area is really helpful so that there's not transmission in healthcare facilities where we've often seen transmission to those that are there and that are quite vulnerable. So a call ahead is really appreciated if someone in particular has recently traveled, is unsure or knows that they're unvaccinated. Those increase the risk of it being measles, and they should call ahead to their provider before just going in to being seen.
Yeah, that heads up phone call can really give the physician's office or the urgent care some time to sort of manage things. You touched a little bit on testing. I'd like to ask Dr. Falardo, what if a healthcare professional has a patient that they think might have measles? What is the testing that we do for measles?
Yeah, we really recommend sort of 2 testing approaches together. So historically, serology or testing for measles IgM was the main modality of testing. And we do recommend still that if possible, a serology specimen or a blood sample be obtained to test for IgM. In conjunction with that, PCR testing is now really also a main modality for detecting measles. PCR can be performed primarily on respiratory specimens, so that would be a nasopharyngeal or an oropharyngeal swab. Both are acceptable. And PCR can also, in some instances, be performed on the urine, generally in conjunction with a nasopharyngeal or oropharyngeal swab. And we do really highlight that a lot of people probably haven't seen measles or thought about measles as much, during the elimination phase. And so we do encourage, testing to be performed in conjunction with local or state health departments. Often the PCR test is done by a state health department public health lab. And so that early sort of notification of public health of a suspect case and that early coordination of testing can really be beneficial.
So that it would seem to me then that even in rural areas who might not have a big academic center right down the street should be able to have access then to testing as long as they have their health department on speed dial.
Yeah, we really can't emphasize that enough. Having sort of awareness of how to contact the local or state health department to report a suspect measles case, and certainly getting that help in arranging testing, especially if outside of an urban area.
Great. Question for Dr. Bell. If a patient has a mask on, let's say they do spend a little bit of time in that waiting room, unfortunately, is there a particular amount of time that we would consider the other people in the waiting room to be exposed? If they're there for 5 minutes, 2 hours, do we have an idea about how much time a masked person would need to be around others before we would worry about that really high R naught?
I wish I could give you an answer. This is going to be terribly unsatisfying, but given the variation in terms of how people wear masks, it's not uniform. If they took it off to blow their nose, if the child was uncooperative, I really don't think you can hang your hat on the mask as buying you a legitimate amount of time. If I were running the health response, I would certainly track everyone who encountered that person. If I were notifying people in the community, I would let everyone who had signed in and was known to have been there be aware so that they can assess their own vaccination status and then seek care and follow up appropriately.
I appreciate that. Sometimes it's not as black and white as we would like it to be, but being overly cautious and notifying everyone seems like the safe bet. I'll pose this question to Dr. Sugarman, but open up to others if it is better for someone else. I remember when I first started in medical school, when I got my first job, they asked for measles titers, right? When I started my job as a physician. What happens if a healthcare professional's titers are low when they start that job? Do they require a booster dose? Do we just say, well, you have the documentation that you had your immunization records are up to date here. Is that good enough? What's the recommendation for those people?
No, it's a very good question. Our guidance is that if you've had 2 documented doses, that is sufficient as a healthcare worker. That said, if you get a titer drawn because you're concerned and it happens to be low, you certainly can get another dose, though that is not required per current guidance to ensure protection. I'll hand it over to Dr. Filardo and Dr. Bell, who may want to add to that.
No, thanks, David. I think you're right. As we highlighted, there's no harm in receiving an additional MMR dose for those who have prior doses and prior immunity. But the current sort of ACIP recommendation on this is that 2 documented doses of MMR is sufficient, regardless of what the results of a titer might be. And so it would not be required per ACIP that a healthcare worker receive an additional dose in that setting.
Great. And Dr. Filardo, I'll come back to you for what will probably be our last question here. We talked about how 1 dose of the MMR is about 93% effective, and then the 2 doses 97% effective, which is really great. Can a fully vaccinated person carry and sort of be colonized with measles and expose others? We know that there's a 3% chance that they might actually come down with measles, but can they sort of hold it and spread it in that temporary sort of fashion?
Yeah, as you highlighted, it's pretty rare for people with 2 documented doses of MMR to develop measles. It represents a really small minority of cases that we've seen in national surveillance during the elimination period in the United States. And it usually only happens in the context of really prolonged exposure to measles. So in a household setting, in the context of repeated exposure in a large outbreak setting. And so we tend not to see people with 2 historical doses who develop measles without a clear source, without really known prolonged exposure. To get to the rest of your question, we think the science on this is not black and white, but we think that people with 2 documented doses who develop measles are much less likely to transmit measles to others. There are, it's sort of on the level of case reports. It has been shown that transmission likely occurred as the result of someone with 2 historical doses developing measles, but it's really limited to very small numbers, we think. And so in general, that's another benefit of vaccination, that pre-existing immunity, even if it happens to get overcome in these rare scenarios with prolonged exposure to measles, means that that person would be much less likely to transmit to others.
Well, thanks. Just another reminder of how effective and how important this vaccine is. So I want to thank you to all of our panelists for taking the time to dive into this topic. There's a lot of concern with measles cases and outbreaks popping up across the country, and it's been great to hear from you experts. I also want to extend my gratitude to our audience. You have brought and always bring truly thought-provoking questions, so thank you for spending this last hour with us. Measles is a vaccine-preventable illness, and if we can improve our vaccination rates, these outbreaks that we are seeing now would dramatically decrease. We need all healthcare professionals to continue to talk to their patients about vaccination as a safe and effective way to halt this disease. A video of this event will be available on this page shortly, and we look forward to seeing you at our future educational webinars.